Hello, everyone. Good afternoon. My name is Anna Fisher, and I have the pleasure of introducing our next guest speaker here. Dr. Natalie Manley is the medical director for Emmanuel Pathways. Dr. Manley embodies a steadfast commitment to compassionate geriatric care. With a medical degree from the University of Nebraska College of Medicine and specialized training in geriatrics from the University of Utah, Dr. Manley brings a wealth of expertise to her role. She is focused on interdisciplinary care management for older adults, including those with complex medical conditions and dementia. She prioritizes the values and preferences of each individual. Oh, how I know that firsthand. Dr. Manley's dedication to supporting caregivers underscores her holistic approach to geriatric medicine, ensuring that each person receives care that aligns with their unique needs and desires. And I'm going to go off script just for a brief moment to say, I'm going to personally thank you for what you do for us givers of care, the recipients of care, and importantly, what Dr. Manley does for the community. You make a difference in people's lives. Thank you. I present to you.
I'm gonna need a copy of that so I can hang it on my fridge. Thank you, everybody. It's good to meet you. And thank you for all that you're doing every day and for taking good care of older adults. We are gonna talk about age-friendly care and potentially inappropriate medications in older adults. The good news is you've had really great comprehensive education today. So a lot of this is gonna be some good review. So, okay, let's see if I can figure out how to make this work. I have no disclosures or conflicts of interest. I will say, so I'm medical director for Emmanuel Pathways Program for All-Inclusive Care of the Elderly. I decided, because I am a lifelong student and I just want to know what's going to be on the test. There is no test. What's going to be on the test and tell me what I need to know. So here's the objectives. I'd like for you to learn by the end of this to know the 4 M's of an age-friendly health system, which I know you've heard that today. So we'll review that. Describe why is it important to understand medication risks in older adults. List at least 3 commonly used medications that are potentially inappropriate in older adults. Explain the prescribing cascade. Name resources and determine medication risk for older adults. And describe methods for managing symptoms in older adults without adding a medication. And the good news for me is you've actually gotten a lot of that education for that last bullet point already today. So I can refer to that. Okay, so the age-friendly health systems project is to try to help everybody get really the really important basics of geriatrics and how to make sure that we're doing a really good job taking care of older adults no matter where you are. So the 4 M's framework was created by IHI in partnership with the John A. Hartford, and the 4 M's are what matters most. That is my absolute most favorite part because it really helps us set the North Star of where are we aiming for. So if I care that your A1C is less than 7, but you care that I want to spend the last days of my life eating as much ice cream as I possibly can, then we need to focus on getting you as much ice cream as you possibly can. And I need to set my goals aside. Medications, which we're going to talk about today. Mentation, which includes both memory and mood, and mobility. So your ability to get around your own environment as much as possible on your own. The American Geriatric Society is also involved in this, and they add a 5th M. I always like to make sure that people know about the 5th M, but the 4 M's I feel like is easier to try to remember. But so multi-complexity is that 5th M, and just really bringing it all together. That in older adults, there's a lifelong history of all the things that have happened in life, and kind of like the layering on of all of the different diseases and issues that can come up as we age. But also factoring in their biopsychosocial needs and spiritual needs and all of those things that come together to make us a whole person. Okay, so that was objective number 1, the 4 M's, which are what matters most: medications, mentation, mobility and multi-complexity. And so why is it important to understand medication risks in older adults? And the answer is because medications impact what matters most, impact mobility and impact mentation in good ways and bad ways. And so it's our job to help kind of figure out which one is which. So as we age, and you get this question a lot from older adults who say, well, I've been on this medication for 20 years and it's always been fine. So why are you telling me I need to come off of it now? Well, it's because our bodies change, our organs change, our kidneys filter differently, our liver deals with medications differently. Every single one of our organ systems changes. And that would be a whole nother chapter of a book. So I'm not going to go through all of those different physiologic changes. But we have the physiologic changes plus the accumulation of chronic diseases. And so put those together and the body handles medications differently after age 65. Some medications are less safe in older adults is what that leads to. And hence the ATS-Beers criteria came to life to help us know which medications we should be extra cautious of. So if you want to boil it down even more, less is more, fewer is better. And really that balancing act of there's a few good things about a medication and a lot of potential side effects that we have to think about. And how does that balance out? I thought this was a really nice article. It's an open access, so if you want to find it, you can. It's an update on the clinical consequences of polypharmacy in older adults, a narrative review. But I really like how it just shows how this stacks on top of each other. So polypharmacy is generally considered 5 or more medications on a person's med list. And that leads to drug-drug and drug-disease interactions, adverse drug reactions, also makes it just harder to adhere to medications. I can't tell you the number of times where people have told me, like, I have a hard time keeping up with my insulin and knowing like how often I'm supposed to take it, or it's too hard for me to keep up. Leads to adverse drug-related events, falls, kidney issues, GI issues, all of the above, which then leads to physical and cognitive changes, frailty, sarcopenia, which is like muscle wasting, and then potentially hospitalization and death. So it really all can add up. Objective number 3, list at least 3 commonly used medications that are potentially inappropriate in older adults. Okay, so this is actually a video that you can watch if you're interested, and you can't see the link right now, but it's on the slides. But this is just a nice summary of medications that are considered to be high risk. So medications that are likely to lead to adverse effects and potentially hospitalizations. So blood thinners, seizure medications, pain medications, diabetes medications, opioids, that one's an easy one. Sleeping medications, blood pressure medications, antipsychotics or anti-anxiety meds, and some over-the-counter drugs. So a lot of common meds that we use all the time and can do a lot of good for people and then can also contribute to bad things as well. So I took that list and then I kind of just rewrote it to help make it a little bit more defined about which medications that we're talking about here. So antipsychotics, so I'm not specifically calling out quetiapine, but that's one of the antipsychotics. We see it a lot because people traditionally have found that they like to use it for sleep. It is not a great medication to use for sleep. And so I'll have more slides on that later, but really in every single situation, the real question is, why is the person having this symptom? Figuring out, like, get to the root cause. Why is this person having this symptom? Because most of these medicines that we're talking about kind of just slap a Band-Aid over the symptom. And so when we're using quetiapine for sleep, you're just using it for its sedative effect, but really it's an antipsychotic. So the real reason to use an antipsychotic in an older adult is if they're actually psychotic. So they actually have hallucinations, they actually have delusions, and those symptoms are causing a problem. So if the person has a hallucination of a cute little puppy dog and they love that little puppy dog and it's not causing them to run and chase after it and cause, like, any risk of harm, then those puppy dogs can stay and we don't have to make them go away. So we really have to think about those things. Benzodiazepines like lorazepam, alprazolam, clonazepam, sleeping medications. So diphenhydramine, that's Benadryl. So if you have patients who are telling you, oh yeah, I take that over-the-counter sleeping medicine I heard about, that one is like that, just memorize that diphenhydramine is horrible. The only reason to really have an older adult on diphenhydramine is if they're having like anaphylaxis. Hydroxyzine, trazodone, Z drugs. And again, because the idea is with sleeping medications, like let's figure out why are they actually not sleeping, and let's get to the bottom of that and let's fix that, as opposed to slapping a medication on it. Again, every single one of these, they're called potentially inappropriate medications because there's some situations, and everybody's individual, and there's special situations where there might be a reason that somebody has decided that their benefit outweighs the risk. Urinary incontinence medications, oxybutynin is super duper anticholinergic. Really, I cringe every time I see oxybutynin on somebody's med list. So there might be a good reason, but you at least want to like have a little bit of a cringe and wonder why. Tolterodine, narcotics, NSAIDs, and this is where it gets really tough to treat older adults' pain because we've got Tylenol, which is safe and effective to a certain extent. NSAIDs have lots of risks in older adults. It causes kidney failure, GI bleeds, lower extremity swelling, high blood pressure. And so it's not great to use long-term NSAIDs. So if we can try to figure out other options to try to treat the underlying cause of the pain, or steroid injections or other things. Again, each one of these lines is like a whole hour-long talk. So I know I'm running through these as fast as I can. Overuse of blood pressure medications and diuretics. So just really being thoughtful, like, okay, just because they needed their Lasix a year ago, do they still need it now? Could we titrate it down? Have they lost a bunch of weight and now they're not eating and drinking like they used to? So really just looking at every single time we're looking at a person, is this still the right med for them? Diabetes medications. So we know now that older adults, especially frail older adults who have multiple medical conditions, if we overtreat their diabetes and get their A1Cs as low as you would want somebody who's younger to have, we're going to have actually increased risk of harm. So increased risk of falls, increased risk of hospitalizations. And so we really need to be more cautious about what we're choosing for their A1C goals to be. And then excess antiplatelets and blood thinners. It's not uncommon, although less common than I think even 10 years ago, where, you know, somebody would be on an aspirin at baseline and now they've got AFib and then, you know, warfarin or Eliquis got added on and they just kind of get left on that aspirin forever. But really real reason to be on both an aspirin, an antiplatelet plus an anticoagulant is if you have like an artificial valve or you've just had a stent placed. But otherwise, you don't really need to be on both. And so you got to just pick one. But again, it's a very thoughtful decision based on everybody's individual needs. So the question was, you know, this person's on Lasix, the diuretic is contributing to a lot of urinary symptoms, and it's really causing a lot of problems for the patient and the family it's really distressing. And the medical team is saying, well, they really need to be on this Lasix. I think then that's a great way to go back to the what matters most conversation and say like, okay, where are we at with your overall health? You know, if a person is saying, I can't live like this any longer, then this might be something where we have to say like, well, we could try to decrease it and see and keep a really close eye, see what happens. But it is like a bit of a dance. But I love titrating people off of their diuretics, and every once in a while somebody will then, okay, nope, you actually really did need it. So, but you have to do it very cautiously and very slowly. And a very frequent touch points is the important thing too. So you can't say like, I'm going to start you on this med, or I'm going to stop this med and see you in a month. Like it has to be like, I'm going to see you in a week for a short touch point. Yeah, good question. Okay, objective 4, explain the prescribing cascade. This is one of my favorite things to talk about. So the prescribing cascade is where you have a person who started a medication for a reason, and now they have a side effect. And then you get that side effect and you come back and you say, hey doc, I've got this side effect. And you say, oh, I've got a medication I could treat that with. And so you give them a medication and now they've got another side effect, and they come back, I've got this side effect. Oh, I got another medicine. And so next thing you know, you're layering all these pills on, but really it's just, you're treating the side effects of all the preceding medications. So this medication, or this nice little depiction here is from the De-Prescribing Network, which comes out of Canada, and that's a really great source. So I'll show it to you here in a second. But here we have a lady who's got depression. She got started on some bupropion to treat her depression. Now she's got some insomnia. And so next step, well, I can treat your insomnia. Here's a sleep drug. So we'll go ahead and give you the sleeping medicine. Well, now she's having some dry mouth, constipation, brain fog. Oh, you might have some dementia. Let's start you on some donepezil. And so, you know, and we'll get you on a laxative. And so next thing you know, we're just like piling on meds. And so that is what you saw in the first lecture this morning, was this patient had a lot of kind of add-on medications that kept adding to her side effects. So here's some other prescribing cascade examples. There's a lot of them. I had to stop myself from just listing a million, but, and you know, none of these meds are necessarily like bad of themselves, right? So like amlodipine is a great drug. It can help with blood pressure and relatively well handled and not many side effects, but it can cause leg swelling. And so this can happen sometimes where a person gets started on their amlodipine. Now they have leg swelling. Oh, I got a medication for leg swelling. I'll put you on some Lasix. Okay, well, now we're having problems with dehydration. And so really think about like, okay, no, actually this is a side effect of the medication. Let's back off and maybe try something else. NSAIDs. So NSAIDs can cause high blood pressure. So now you're on blood pressure meds and you kind of just keep going and going. Can also cause GI upset. So now we're putting you on medicines for GI upset. So there's just any number of medications that we could do this with. That's another one, right? Like Lasix. Oh, now I've got urinary incontinence. Oh, well, here's some oxybutynin, and now you're like now you're dehydrated. You've got urinary retention, so we'll put a Foley in. And yeah, so that's why I love the prescribing cascade. Okay, next. Name some resources to determine medication risk for older adults. So this is the one where I actually want to spend a little bit of time on because this is a short talk and it's full of information that is hard to carry with you, and you kind of want something that you can take in the trenches with you. So this is going to be a bring your own device kind of activity. Here's some really great resources that you can carry with you. So AGS Beers criteria is very well known and can be really helpful. You can Google the AGS Beers criteria. There is an app for it. You have to pay for it. I do not work for AGS, so I don't think it counts as me selling anything. Deprescribing.org is a really great resource based out of Canada and has lots of great resources. And I'll take you through a couple of things that they've got here. There's a USD Prescribing Research Network. The Stop Start Toolkit is another one that people know. It's a little bit, from my perspective, I've had a harder time figuring out how to navigate it because it's a big PDF file, but they've got some good stuff on there too. Okay, now there's the AGS Choosing Wisely. Have people heard about Choosing Wisely? So American Board of Internal Medicine, probably like 10 years ago now, put together this Choosing Wisely thing and got all the different organizations to say, what are the things that really you wish everybody just knew? Like the questions that you see all the time or things that you kind of commonly see that you wish people knew. And so then the different organizations came together and came up with expert consensus of like, these are the things that really annoy us and we wish everybody knew it. And 10 years later, these are still super relevant. I refer to them all the time. I use them a lot to educate my patients and say, look, it's not just me saying that you shouldn't be on this med. Like this is like what all the experts say. So I'm going to kind of painstakingly take you through this because I think they're really good. And I would just encourage you to go to Google and type in AGS Choosing Wisely, and this will pop right up. So number one, don't recommend percutaneous feeding tubes in patients with advanced dementia. Instead, offer oral assisted feeding, although I have a thing with the word feeding, I'd rather say like assisted eating. But the idea is with people who are having progression of their dementia, progression of their illness, to the point that they're not eating, that is a progression of their illness. They are dying. And if we force a feeding tube into a person, we are actually causing more harm than good. And they've done research studies and found that we actually cause a lot of distress and we actually don't help people. So that can be something where you can educate family members earlier on, like, hey, you know, I know things are going well, but someday your mom might lose weight. And it's important for you to know that if somebody ever offers you a feeding tube, the answer is probably that you don't want to do it. So that can kind of just help prepare them. Number 2, don't use antipsychotics as first choice to treat behavioral and psychological symptoms of dementia. I think you've gotten to see a lot of that today in the talks from today. Avoid using medications to achieve a hemoglobin A1C of less than 7.5% in most older adults age 65 and older. Moderate control is generally better. And there's some nice charts that you can look for like age appropriate A1C goals. And you can find those based on what their frailty status is and life expectancy. Don't use benzodiazepines or other sedative hypnotics in older adults as a first choice for insomnia, agitation, or delirium. So instead focus on what are some of the other things that we can do to help with their sleep, such as sleep hygiene. Don't use antimicrobials to treat bacteria in older adults unless specific urinary tract symptoms are present. So we don't normally think of antibiotics as a potentially inappropriate med. But if you figure there's plenty of people who have asymptomatic bacteria that's just hanging out, they might just be living with it, then we don't want to be treating people's asymptomatic bacteria when they don't really have an actual UTI. So you have to look for like the real symptoms. So that's the McGear criteria that you hear about. So because otherwise then we're going to end up having resistance and GI side effects and all of those things. The other thing, my little soapbox is, I know like probably 15 years ago, I think geriatrics, we all walked around and said, hey, if somebody's confused, it might be a UTI, so everybody check a UA. And now we're kind of like backtracking and saying like, well, yeah, it could, but there's also like 10 million other things that this confusion could be. So like, don't forget, it could be constipation. It could be that their electrolytes are out of whack. It could be a variety of things. So it's not always a UTI. Don't prescribe cholinesterase inhibitors for dementia without periodic assessment for perceived cognitive benefits and adverse GI effects. So, Aricept or donepezil, is really intended to help slow the rate of dementia. And so if a person has advanced dementia and they're losing weight, what good is that donepezil really doing for them? So just really kind of constantly thinking about, is this still the right medicine for this person? Don't recommend screening for breast or colorectal cancer or prostate cancer without considering life expectancy and the risks of testing over diagnosis and treatment. So you could say like, even like chemotherapy could be a potentially inappropriate choice if this person already has kind of a limited life expectancy. And so this really has to do with primary prevention screening. And I have a nice little tool I can show you as well to help you kind of decide through, is this the right thing or not? Avoid using prescription appetite stimulants or high calorie supplements for treating of anorexia or cachexia in older adults. Instead, optimize social supports, provide eating assistance, and clarify patient goals and expectations. And so one of the ones that we think of, we think of some of, I'm blanking right now on the name of the medication that we use for mirtazapine is one, but what's the other one that I'm thinking? Megace. So Megace, thank you, has a lot of weight gain is actually from water retention. And so you're not actually providing like nutritional weight gain, and it can increase risk for blood clots. So really have to just think about what are the underlying reasons that this person is losing weight, and not trying to cover it up with a Band-Aid. We do know if somebody's losing weight because of depression, then that's a reasonable reason to treat with an antidepressant. But using mirtazapine as like purely just for weight loss and not like in the absence of depression, that's not going to do a lot of good. Don't prescribe a medication without conducting a drug regimen review. So that's the prescribing cascade. And then avoiding physical restraints. And I would like to add to this, avoiding chemical restraints, right? So that's where the medications come in, is if we're annoyed by somebody's behavior and we slap a benzodiazepine on to help them not bother us at night or something like that. Okay, so this is the Jerry Pal podcast website. Has anybody heard of it? I love it. They have amazing speakers that come and talk, and it's just really conversational. So I would highly encourage you to pull up the Jerry Pal podcast. They have a whole hour on the AGSBR's criteria for potentially inappropriate medication use. And I think you can submit for CME if you take the time to do it. Okay, this is from deprescribing.org. So again, that's the one from Canada, but they have these really great little tools then that you can click on. So you have proton pump inhibitors for, it tells you how to get people off of certain medications, antihyperglycemics, antipsychotics, benzos, cholinesterase inhibitors. And so if you see here, here's the hyperglycemic one. So it helps you walk through, like, is your older adult with type 2 diabetes, do they meet these criteria? Are they at risk of hypoglycemia? Are they having an adverse effect from their antihyperglycemic? If yes, let's set individualized goals based on their comorbidities and preferences. So it just adds like a nice little tool that you can use to help make decisions. So the big question is, well, okay, that's great. How am I supposed to know what their prognosis is? And so, you know, we know they've done research studies, and physicians and providers are pretty terrible at actually knowing when a person's going to die. We can do our best in our estimated guesses, but so they've come up with some tools to enter in the patient data and figure out a little bit more of a sense of, on a population level, what's this person's estimated prognosis. So this is ePrognosis. If you just Google, have you noticed I love Google? ePrognosis, this will, it'll be like the first thing that pops up. And so they have different tools. They have a prognostic calculator. And what they do is they actually take like all the different prognostic calculators, or a variety of prognostic calculators that have been created, and then they help you pick which is the right one for your circumstance. They have a nice time to benefit tool, and then also cancer screening tool. So they'll take you through, like, what's this person's ability to push furniture? How do they have lung disease? Do they have heart disease? Do they have a history of cancer? And you go through all these questions, and then based on that, it gives you this nice little, like, kind of readout at the end that you can show the patient, and it'll say, like, look, you are, like, I'm going to hurt you if I have you get a colonoscopy, for a screening colonoscopy. So it helps to guide that conversation. So here's the time to benefit tool. I just clicked on it and gave you an image here. So it'll tell you, like, okay, well, so in order to have adequate time to benefit for primary prevention screening, colorectal cancer screening, you need to have a 9-year life expectancy. Mammogram, 10-year life expectancy. Bisphosphonates, less, so like more like a 6-month life expectancy. Intensive glycemic control, so 9-year life expectancy for it to really be valuable, to be on intensive glycemic control. Less for the intensive blood pressure control. In terms of the blood pressure control, don't ever flinch about getting orthostatics. People will surprise you. They might say, no, I'm not dizzy when I stand up, and you get their orthostatics and they're quite orthostatic. So it's always good to consider getting orthostatics. This is the stop-start tool. If you go through this, then there's some different things that you can click on that will help you work through medications. And then the niche program, they also have some really nice resources as well. These are mostly patient education tools. So you can click on these and have them give you education tools that you can hand out to your patients. And then healthandaging.org, that's the American Geriatric Society. They have so much information on here. The healthandaging.org, that's the consumer focused part of AGS. And so lots of things that you can use to educate your patients as well. Prescribed methods for managing symptoms in older adults without adding a medication. So I know you've already seen a lot of these over the course of the day. So hopefully some of this is review, and maybe there's a few new things in here for you. I thought we'd do a little case, and actually I just stole this case from this nice Donna Fick, Barb Resnick. They're kind of like big names in geriatrics. And so they put together this article back in 2012, how should practicing nurses use these criteria? So this case came from there. So Miss W is an 82-year-old woman who has had, and what I want you to do is just kind of look through this and see, like, what medications do you think might be contributing to problems for her. 82-year-old woman who has had 6 emergency department visits in the last 8 months due to falls. Her past medical history includes dementia, diabetes, hypertension, congestive heart failure, and osteoporosis. Mrs. W sees 3 different providers and is taking several medications, including acetaminophen, duloxetine, Docusate, glyburide, amlodipine, losartan, and hydrochlorothiazide. Her physical function has been declining for some time, and there are questions about her safety because she lives alone and has been falling. Mrs. W can perform all of her activities of daily living, but a daughter who lives nearby assists her with most of the instrumental ADLs. Her daughter handles all finances because she feels her mother cannot. So I'll stop there, and if you can just shout out for me, what medications on here might be contributing to falls? Except for maybe the Tylenol. Yeah, so pretty much all of them could in some way or another contribute. And so then it's that question like, well, is she orthostatic? And we need to kind of work through that. What's her A1C? Is her blood sugar is actually lower than they need to be? So now Mrs. W, she was recently hospitalized for an exacerbation of her CHF. While she was in the hospital, her functioning declined. She became hypoalert with new onset incontinence and was resisting care. She was given lorazepam. Doesn't this sound exactly like what we just talked through this morning in the emergency department? And once transferred to an inpatient unit, was continued on lorazepam as needed every 6 hours. She's adamant that she wants to go home and that she can do so independently. So this is a much bigger case, right? Like we've got the what matters most here. Like how are we going to help her achieve for what matters most? And that might factor in goals of care. What do you think about the lorazepam? Not my favorite. So, and the question is, you know, so she's got delirium. And so what are we going to do to help figure out the underlying cause of that? Okay, so what is the first thing you should do before passing a medication or reaching for a PRN or prescribing a PRN or anything? Stop. Just stop. Stop and just think about like underlying causes, non-pharmacological management. What are some other things that we could do? Sometimes that little pause really can help. So some things to consider. Is the symptom a side effect of a current medication? Is it a side effect of an OTC medication or a supplement that maybe they didn't tell you they're taking? Is it a side effect of alcohol or drugs that they haven't maybe mentioned? An undiagnosed problem such as sleep apnea, an unmet need. Are they tired, hungry, thirsty, annoyed, overstimulated, understimulated? Is there potential abuse going on? Is there constipation? So all kinds of things to consider. So here's just a nice little tool that I found that has a nice pictorial of some other things that you can do for non-pharmacologic interventions for pain or agitation. So relaxation or imagery, superficial massage, breathing techniques, music therapy, spiritual practices. I have a favorite story of a lady who I was doing, it was early on in me starting to do hospice work. And they called me and said, hey, somebody's really having a lot of symptoms and we need to start a med. And then about 10 minutes later, they called me back and said, actually, the chaplain came and prayed with them and they're fine. So we're good. I was like, that's fantastic. So then I didn't have to log in and write anything. Here's one hospital's method for a non-drug sleep protocol. So some nice relaxing aromatherapy lotion, some herbal supplements or some herbal teas, and some nice music. So here's the National Sleep Foundation sleep tips for 10 tips for a better night's sleep. So going to sleep and waking up at the same time every day, having a nice relaxing bedtime routine, making sure the bedroom isn't too hot or too cold, making sure it's nice and quiet when you go to bed, the bedroom is dark. And really, I don't have to read through all of these, right? But just making sure that you're taking your patients through, like, well, are you doing these things? And where might there be places where we could adjust your sleep routines? It's not uncommon, and this just came up for me earlier this week in clinic. The patient said, I'm really having a hard time sleeping. And he was already on like a whole bunch, he's actually on like 3 sleep meds. And I said, well, what time are you going to bed at night? 8. Okay, well, are you tired at 8 o'clock at night? No. Well, why are you going to bed? I'm just bored. Okay, so let's maybe try to go to sleep a little bit later. What do we need to do to deal with your boredom? And it was interesting because he said, well, it takes me like an hour to fall asleep. And then once he falls asleep, he's sleeping for like 7 hours. So I was like, okay, so we might need to reset some expectations here, but sometimes just helping work people through like, let's get into the fine details of exactly what your sleep process is, can really help to unmask what's actually going on. This is like my brief. I was like, well, I know it's like a whole nother talk about psychological symptoms of dementia, so I'll throw something at you guys here. This is the tool that I learned when I was in fellowship, the ABC model for dementia behavior management. So A stands for antecedent, B stands for behavior, and C is for the consequence. So A is like, what's the trigger? What's the thing that's like causing this person, or what's going on before the person starts having this behavior? B is what's the behavior, because it's easy to say, oh, this person's having behaviors. What is the behavior? Because there's a big difference between punching you in the face or standing up to walk around the room. And I know it happened to me kind of early on where I got called into a room because somebody was really sedated and they had just gotten their Ativan. And what did they get the Ativan for? Oh, well, they were having a lot of behaviors. What was their behavior? Well, they kept standing up. Okay, well, why were they standing up? So that's where it's like, let's really get into the nitty gritty of what is the actual behavior and describe it. And so then C is like, well, what's the consequence of the behavior? Is it actually causing risk of self to harm or others? Is it kind of mildly irritating? And like, is it a matter of that we just need to educate the caregiver about how to do self-care? Hence the need for caregiver support resources. So that was my 2-second version of managing psychological symptoms of dementia. And there's a million great resources out there. So that is it. What questions do you have? Go ahead.
What is your take on supplements as an alternative to the meds?
I think you just have to be careful, especially because they're not regulated by the FDA, right? So you don't actually know necessarily what you're getting in the supplement. So it depends on what you're talking about and which particular supplement.
I get asked that by patients all the time, like, I be taking turmeric instead of my high blood pressure medicine, or that, that.
Right.
And I'm like, well, I'm not a doctor, so you go back to your primary care.
Yeah.
But yeah, all the time.
It's a question that I think stumps everybody, is like, well, how am I going to respond to this? Because I want to align and not kind of alienate the person from thinking that I'm just one of those medical people who hates all natural things or something. So sometimes I'll just say it's, from a medical perspective, we don't have the data to support it. And so there's not proof. And sometimes I'll pull up whatever resource I can find, and then say, you can spend your money on it, but you might just be kind of throwing your money down the drain, literally. So good question. Yes.
Can you speak to melatonin?
Okay, melatonin I do like, actually. I think melatonin is one of those things that if you need to start something, it's a nice kind of less risky option. But again, is it really is there something else underlying going on that we can identify? Again, Dr. Ruth, I look at you here. I got taught if you were going to use melatonin, to use it a few hours before bed, so it has time to kind of work into the system. So yeah.
For someone who said try melatonin doesn't work, what's the next? And say you're adamant.
And they're adamant for a medication. That's when I think I keep deferring. I try to defer as long as I possibly can. So that's where then sometimes I'll really start harping on maybe you have sleep apnea. Maybe we need to do a sleep study. Maybe we need to are you using your sleep meds? Your CPAP. If I'm absolutely stuck in a corner and I'm forced to use something, I'd probably use trazodone, but I would use the very minimum, 25, and say we can try this for a little bit, but let's try to back off if we can. And sometimes you just get back into a corner. The other thing I was going to say about melatonin there is, if somebody has sleep-related behavior, like sleep-related movement disorder with their like Parkinsonian symptoms, that can be really helpful. And that's actually really fun to help people with a little melatonin and have them stop falling out of their beds. Thank you guys for being here.
That concludes the online education. I would like to thank all of our presenters for their experience, knowledge, and expertise. Be sure to subscribe so you're up to date with all of Nebraska Methodist College's continuing education offerings. Thank you.